Hello and welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Ceramelli and I oversee Grand Rounds for our department. Just a couple of points about Grand Rounds before I talk a little bit about today's presenters. First, I encourage you to write any comments or questions into the Q&A or the chat, whichever you prefer. There'll be time for discussion and questions at the end, and I can go through those with the presenters. You could write those in anytime, early, halfway through, whenever you like. There's a group of us that work on the Grand Rounds series and the presentations each week, including Semhar Abraha and Mike Walker. We do record and archive almost all of the presentations, which are on the Grand Rounds website, on the department website under Education. This year's series is funded by the Ripley Fund and the Garvey Institute for Brain Health Solutions. And close to the end of the presentation, I'll put a link in the chat that has takes you to a couple of evaluation questions. I encourage you to complete that, or you could always just write to me with any comments or feedback about the Grand Round series. Now for today's presentation. Today we have a joint presentation to talk about the new, well, we were just talking now, this has been around for 5 years, the UW Behavioral Health Institute at Harborview. Talk about the vision, strategy, the work that's being done there, and plans for the future. And we have two people here presenting on this, Dr. Susan McLaughlin and Melody McKee. Now, Dr. McLaughlin is the director of the Behavioral Health Institute, which I mentioned is at Harborview. Dr. McLaughlin is a licensed clinical psychologist with years of experience in leadership in behavioral health and social services. Notably, Dr. McLaughlin was founding executive director and CEO of Healthier Here, which was the ACH of King County. Melody McKee, the joint presenter today, also works in the Behavioral Health Institute as the program director for Behavioral Health Training, Workforce, and Policy Innovation Center. Melody is a licensed SUDP and has worked in behavioral health for almost 20 years. She has participated in advocacy work at the local and state levels and is a founding member of the Washington Recovery Alliance and serves as an executive board member on that board of directors. I have kept my introductory remarks somewhat brief today. I want to get to the presentation. Usually when there's two people, it's good to get to the presentation. So I'll stop there for now and turn it over to today's presenters.
Thank you so much, Joe, and thanks everybody. It's great to be here today. I'm so excited and honored to be invited to share space with you today. So thanks for joining us, Melody and I, to hopefully introduce you to the Behavioral Health Institute, as Joe was saying, at Harborview. I'm relatively new, so I just started about 7 months ago. Melody has been with the BHI almost since its inception, and she's been making great things happen in our Training, Workforce, and Policy Innovation Center. So I'm really thrilled to have her join me today to tell you about our work. So we are going to tag team a little bit. I'm going to kick us off, and Melody will talk about our work in training, the training workforce as we get there. Our presentation, I think, will be a little bit different today than most Grand Rounds in that we really are here to introduce you to the BHI, even though, as Joe mentioned, we've been around for 5 years. We've really been hitting our stride in the last couple of years and evolving into kind of who we are. We want to share a little bit about what we've been doing and then where we're going. And we hope that it'll get you thinking about potential intersections with the work that you do and opportunities for partnerships. As you'll hear and see, as Melanie and I talk, the BHI really aims to be a facilitator of system change, not by doing it all ourselves, but it was designed to draw on the vast expertise that already exists within the University of Washington and Harborview, and to support our community behavioral health. So if you can go to the next slide. Thanks, Melody. As we mentioned, the BHI was originally conceptualized back in 2017 by a group of folks at Harborview, at UW, at King County. So I think some legislatures were involved and other community partners, all of whom were already seeing the increased need for effective behavioral health treatment and were acutely aware of the challenges that the behavioral health system was facing in terms of payment structure and rates, infrastructure, and then big system changes that were starting to happen, like the transition to integrated managed care. So the idea was, let's create a center of excellence where innovation and research, training, and clinical practice can come together to advance behavioral health treatment. And it was intentionally located at Harborview, since Harborview is a core provider of behavioral health services in King County and also across our state and the 5-state region, treating some of the most vulnerable populations who are experiencing some of the most complex mental health and substance use disorder needs, often with co-occurring medical needs as well. If you go to the next slide. So after a few evolutions, the BHI now is situated directly under the CEO at Harborview. So I report directly to the Harborview CEO, and we're governed by this leadership team, they call it the steering committee, across Harborview, UW, and UW Medicine. And you can see participants and who's on that steering committee. Next slide, please. As I mentioned earlier, the charge of the Behavioral Health Institute is to bring together the expertise that exists at Harborview, UW Medicine, and across the university to address some of the many challenges facing Washington's behavioral health system. We are doing this through clinical innovation, training and workforce development, and research and evaluation. And then we also aim to serve as a regional resource to improve behavioral health outcomes and advocacy or advance policy in support of sustainable system change. So we're going to talk a little bit about each of those in more detail in just a minute. Next slide. In alignment with the overall vision of UW Medicine to improve the health of the public, the BHI's vision is to ensure there is equitable access to effective, efficient behavioral health care, particularly for individuals with complex health and social needs, when and where they need it. Next slide. So the idea is that we would catalyze and test innovations in behavioral health treatment in our own clinical settings. We have inpatient and outpatient services across Harborview or within community behavioral health settings. We would evaluate those practices and then we work to scale and sustain them through workforce development, through training, and through policy change. So we're going to go through each of these steps in a little more detail and give examples of how we've been doing this. You can advance a couple slides, Melody. Yeah. So at the BHI, one of the things that we're doing is working to close the gap between research and practice by bringing innovative practices into, as I mentioned, directly into our clinical care settings by developing strategies to scale and sustain those practices, all with the goal of reducing disparities and improving outcomes for individuals with complex mental health and substance use treatment needs. Over the past couple of years where we have really been focused on this, we've been doing this in two areas. First, for individuals experiencing a first episode of psychosis through our STEP program. And the second is testing a new model and new technology for reducing suicidal ideation and attempts through our emergency response for suicide prevention, or ERSP. So I'm going to talk a little bit about both of those. The Specialized Treatment for Early Psychosis, or STEP, was a program that was led by Dr. Carolyn Brenner over at Harborview, medical director of our Harborview Mental Health and Addiction Services, and Sunny Lovin, who's the director of our outpatient services. And the way this happened is Harborview's clinical programming identified the need for more evidence-based approaches to treat first episode psychosis. We were seeing high numbers of youth and young adults coming through the emergency department and also on our inpatient psychiatric units who are experiencing their first break. So this was the very first clinical project under the BHI. The team worked with the steering committee at the time for the Behavioral Health Institute, clinical services at Harborview, the UW advancement team, as well as other experts in treating psychosis in UW and throughout the university, developed a campaign to raise resources. And this project or program was initially supported by some philanthropic gifts that came from that campaign. Next slide, please. The program was then developed and incubated at the Behavioral Health Institute. STEP utilizes an evidence-based approach to treating and supporting individuals who are experiencing a first episode psychosis and their families, because we all know that earlier that you treat psychosis, the better the outcomes. And so we pulled in and partnered with the Spirit Lab, which is part of the department, to help design and train staff. All of the staff were drawn from existing outpatient services staff, and then worked to implement and refine a treatment program for folks having their first episode of psychosis. The funding that we received supported a multidisciplinary team, included everything from the program director to psychiatric support, peer specialists, clinicians. And then one of the things unique to Harborview STEP team is that it also funded a part-time nurse to address cardiovascular risk and other health conditions that are common side effects for certain medications taken for psychosis. So it supported that whole team. We worked with the faculty at the Spirit Lab to train and implement and tweak and enhance and do some continuous quality improvement to get the program running right. And since it launched in 2019, we have served 84 individuals under the STEP program experiencing their first episode psychosis and their families. And the most exciting thing is that STEP has now officially joined a statewide network of programs focused on first episode psychosis called the New Journeys Network, and is now fully funded by the State Healthcare Authority and state dollars. I think this is a really good example of and represents how the BHI wants to function, in that, you know, a need is identified. We work with experts in the field to design, incubate, improve upon the treatment, and then scale, spread, and sustain it, and then move it. So the STEP program is now moved fully under the outpatient behavioral health services at Harborview, and the BHI can then move on to a next innovation and next project to innovate around. Next slide, please. Just another example of the clinical innovation we've been working on is our emergency response for suicide prevention. And this is a one-year grant program that was funded by the Substance Abuse Mental Health Services Administration in partnership with our state healthcare authority. And the program was aimed at innovating Washington's behavioral health crisis response specifically to suicide, and particularly in response to the anticipated increased suicide risk that we were seeing in association with the pandemic. So this project went on in late 2020, mostly through 2021 was the one-year implementation. Through the ERSP project, the Behavioral Health Institute and its partners trained about 4,000 behavioral health providers through Washington State in suicide prevention. So this is our part of our developing the workforce and scaling and sustaining. And then it also had a direct service component that supported 232 adults who experienced suicidal ideation or had a suicide attempt during the grant period, started about December 2020 through January of 2022, so about 13 months total. These were folks coming into Harborview's emergency department, as well as we had a couple of partnering emergency departments, some inpatient psych facilities, and a domestic violence site, both in King and Stevens County. So we were spread across Washington a little bit. And it utilized a peer support navigation staffing in the emergency departments, which at least for us here at Harborview, was brand new to introduce the use of peer support specialists in the emergency department. And the other unique thing that this program did was test a new digital platform called Jasper Health. That is a digital platform that supports safety planning, lethal means counseling, psychoeducation, skill building, has some shared story videos on it, and other care planning aspects that the peer would use to work with the individual in crisis, and then they would be able to use the technology also when they transitioned home and to support their community outpatient. So with that, I'm going to turn it over to Melody, who's going to talk a little bit about our workforce and training pillar at the Behavioral Health Institute. So Melody.
Yeah, thank you so much, Susan. I do want to backtrack just a second and with the ERSP program and be sure and mention that it was with our great colleagues from the Ames Center that we developed the suicide prevention training and offered it on their platform to 4,000 providers across the state. So just want to call out that additional collaboration. So yeah, thank you for having us today. And I'm here specifically to talk about the portfolio of projects, and we're just going to highlight a few that are happening in the training, workforce, and policy pillar at the BHI. I'm going to highlight our behavioral health apprenticeship project, our telebehavioral health work, and a law enforcement training project. These are a few projects among an entire portfolio. And, you know, our main mission in this pillar of the BHI is to collaborate with community and university partners and to engage in really statewide collaboration around increasing the robust nature and diversity of the behavioral health workforce, and then also offering equitable access to training to behavioral health providers across our state. So the first project I'm going to talk about is the Behavioral Health Apprenticeship Project. This was or is a continued collaboration between the training fund, the SEIU 1199 Multi-Employer Training Fund, and the BHI. The training fund brought the expertise of the model of apprenticeship, and the BHI brought the expertise of behavioral health together in this great partnership. And with generous gift from the Balmer Fund, we were able to stand up our behavioral health apprenticeship program. In addition to the generous gift from Balmer, the project itself received funding both from King County and from the state legislature as well. Most recently, in the last session, we've received continued funding from the legislature to help expand the program. So the primary premise of the apprenticeship model is that apprentices earn while they learn. So it increases access into the workforce for a diverse array of folks. And while they're earning and learning, they are receiving college credit across our 3 pathways. Behavioral health apprenticeships don't always offer college credit, or apprenticeships don't always offer college credit, but ours is specifically designed to do that with the idea of articulation in mind and people moving on to further degreed pathways. So the 3 pathways for the apprenticeship project that we've started with are the peer counselor pathway, behavioral health technician, and the substance use disorder professional. And currently we have 16 employers across the state participating. We've got 69 apprentices enrolled, and our additional cohorts that are coming over the next several months will add an additional 65, I think, 70 apprentices, somewhere right around there. And the main goal of the apprenticeship model is to help diversify the workforce, create additional pathways into the behavioral health workforce, and increase the number of people that can provide vital services. I'm sure anyone listening today who's in any way connected with behavioral health understands the critical nature of our behavioral health workforce crisis. And this is an innovative approach to that's dedicated to the pipeline part of the workforce crisis. The next project I'm going to talk about is our telebehavioral health project. This started back in 2020 when the pandemic showed up, and the healthcare authority approached us about providing some telebehavioral health training to a community of behavioral health providers who had not previously delivered care virtually. And so we partnered with Dr. Brad Felker from the Department of Veteran Affairs and Department of Psychiatry and Behavioral Sciences at UW and UW Medicine. And Brad has been an amazing leader in this work and amazing partner. And the lead of our, from the BHI staff perspective of this effort is Cara Tal. And the project started with a series delivered via webinar. And eventually we partnered with the NRTRC, that's the Northwest Regional Telehealth Resource Center, to package those trainings and put them on their LMS platform. So these are just some details about the training. It's actually had an incredible reach. Even today, 3 years later, we continue to have 100+ folks attend our monthly webinars. And so that just shows the interest and the continued need for this type of training. Again, our trainings have been delivered webinar and in an LMS platform online. We've delivered 20,000 hours of accredited Category 1 CMEs and continuing education hours, and have had about 10,000 learners across both platforms. An article of the work that's been led by Dr. Falkern and Cara Tal was recently published, and we've provided a link here that you can, I'm sure it'll be emailed out to the group where you can learn more about the article that was published. And we just recently hosted the very first Telebehavioral Health Summit, also delivered virtually, and we had about 1,600 registrants for that. One other project that we worked on was with Dr. Sarah Walker out of the UW CoLab, where we partnered with them to provide a report to the Healthcare Authority around telebehavioral health best practices for youth and young adults, looking at the age prenatal to 25. And the last project that I'm going to talk about is our law enforcement training project. I'm sure many of you have heard of the Supreme Court's decision a couple years ago that was aimed at decriminalizing felony possession in our state, simple possession. And as a result, the legislature put together a bill called many refer to it as the Blake Bill. It's Senate Bill 5476, and this was a very small portion of the entire bill, but it was focused on standing up training curriculum to be embedded into the basic law enforcement academy at the Criminal Justice Training Commission around educating incoming law enforcement officers about interacting with folks who have substance use disorder, including co-occurring disorders and mental health conditions, and providing resources and information to help referral to treatment and the unique referral process for youth as well. So the BHI, we partnered with Dr. Mandy Owens out of UW's ADAI for this project, and we developed the curriculum, and our first iteration of that curriculum was delivered in August of 2022 to the first cohort passed the deadline at the Criminal Justice Training Commission, and it is now a part of their regular 18-week basic law enforcement academy that incoming officers attend. And now I'm going to hand it back over to Susan to talk about policy.
Thanks so much, Melody. And yeah, I think right to date, the training workforce development and policy arm or pillar of the BHI has done a tremendous amount of work. There's huge need, and I think to Melody's earlier point about our goals, this goal of equitable access to training is really important. There are a number of providers and provider organizations, as well as community members and folks like Training Academy that need to understand, have more awareness and have access to training and best practices, and may not have access to the resources to pay for those trainings. So we really work to be able to put things out there into the community that will help. So thank you, Melody and team, for all the great work. I'm gonna just the sort of other piece of this pillar is our policy and convening work, and at the state, regional, and local levels, we work to provide program and policy guidance that will help to improve behavioral health services in our state. And so we currently have, as examples, 2 projects that we're working on in this space to support policy change. So the first one is our Crisis Response Improvement Strategy, or CRIS for short. So this came out of 2021 legislation, House Bill 1477, that was passed that year. Washington State was the first state to pass comprehensive legislation around implementation of the 988 rollout. 988 is the federal crisis and suicide prevention line. and number. And so we were the first state to begin to work on a full-scale redesign of a statewide crisis system as the 988 line was rolling out. And in that House Bill 1477, it directed the state's Office of Financial Management to directly contract with the Behavioral Health Institute to help facilitate and convene this work. And so we've been doing that since about late 2021. And in fact, there was a bill in that just this session that just ended, House Bill 1134, that has extended that work for another year. It was supposed to wrap up in January of 2024, and now it will wrap up in January of 2025. Our ability to do this work was made possible with the generous support of Balmer Group. So they are funding the BHI to do the facilitation and convening of the CRIS committee, which is a 36-member multi-stakeholder system committee, including, kind of all the major players in a crisis response, from providers, state agencies, the 911 system, first responders, EMS, the call centers, and including a number of people with lived experience participate on that 36-member stakeholder committee. There's also several subcommittees that work under the CRIS committees that are subject matter experts in different areas. So it includes things like there's a training, licensing, and credentialing subcommittee. There's a technology subcommittee focused on technology platforms and interoperability. There's a committee for individuals with lived experience. We work very closely with the tribes and the tribal behavioral health committees as well. And then there's a steering committee, a small steering committee that kind of guides all this and is responsible for ultimately submitting a recommendation report to the legislature. Again, that final report due in January of 2025, to include things like a statewide stakeholder-informed vision for what an integrated crisis response system in Washington should look like. There has been work to do a current state assessment of crisis services and resources that are available across Washington state. The State Healthcare Authority and the Department of Health completed a technical and operations plan for the technology to support the call centers and the subsequent mobile crisis teams and crisis stabilization services that will follow. And there is currently a request for information process going on, and that will ultimately lead to a request for proposals to purchase a technology platform for the state, or interoperable platforms to be determined. Also, regular progress reports that are submitted annually to the legislature about the work, and all of those are available online. And when I have a moment, I'll drop the link in the chat for those of you that are interested. You probably know that the 988 crisis and suicide prevention line went live in July of 2022. Washington was also the first and only state to date right now that has a specific Native and Strong line for individuals who are tribal or indigenous or Native, and that went live in November of 2022. So all answered by Native Indigenous peoples, and particularly for that population. Excuse me. So this work will continue and is, again, sort of this whole looking to be a whole-scale redesign of the crisis response system in Washington state. Here at Harborview, it kind of in parallel, and you'll hear more about this when I talk about sort of where we're going. We've also been working over the last 7 months that I've been here on designing our own crisis receiving services. Harborview currently operates psychiatric emergency services as part of our emergency department for people who are in a mental health or substance use disorder crisis. Crisis receiving services will allow us to expand our ability to provide a different, more therapeutic response to individuals in a behavioral health crisis, and offer levels of care that aren't available right now. So you might have somebody come in a crisis. They don't necessarily need to be in psychiatric emergency services or on an inpatient unit, but need a safe place to go where there are trained people to respond to the crisis and help them to stabilize, develop a plan, and transition back to the community. So work is going on simultaneously in Harborview around that, our clinical response to crisis. Next slide. Oh, actually go on ahead. I might have forgot to tell you to advance. I'm sorry. The other body of work that I wanted to talk about a little bit is our race, equity, and social justice and behavioral health work. And this is something that's very important to me and near and dear to my heart, and something that is much needed today. So we have been, since the inception, or almost the inception of the Behavioral Health Institute, we have been sponsoring a race, equity, and social justice conference. We just had our third annual conference in September of 2022, and planning is already underway for our fourth annual, which will be held this fall. Our last one was attended by nearly 1,000 people. That was double the attendance of the year prior, from 37 different states and Canada, Croatia, and Finland. So we're starting to get quite a bit of significant reach there. It's clearly a very important topic, and a lot of work needed to be done in this arena to help reduce the disparities and create equity in the system. One of the other things that we have been doing in between the conferences is a call to action series. The idea here being to take information learned and themes within the conference and then bring it closer to home and work locally with providers and communities in Washington State to help identify actionable steps at the agency system level that can create that sustainable system change. And so we've done that in a couple of different ways. Our current call to action series has been focused on a series of convenings to address the mental health needs of the Black community, including workforce issues, cultural relevance and responsivity of care, and just really what kind of a system is needed to better meet the needs of that population. So that's been an ongoing body of work. We also have a contract with the State Healthcare Authority where we're doing some what I would refer to as phase one work around better understanding some of the root causes and drivers of behavioral health inequities in Washington State. We've done some surveying and some listening sessions. We've done quite a bit of research about what's out there in the evidence right now, and pulling that together to help the state think about a path forward in this area and how to create system change there. So we're working on the final report of the information that we've gathered to date through our surveys, our focus groups, and the subject matter expert work group that we're convening. And so we'll submit that, and then hopefully there will be some ongoing and next steps related to that work as well. Next slide. And then the last pillar of the BHI is our research and program evaluation. The idea here is that we would support conducting state-of-the-art clinical research and program evaluation to improve quality of life for individuals who are living with mental health and substance use conditions, and also to create opportunities to discover what will improve recovery for people living with mental illness and substance use. So this is probably our least developed pillar at this point, but it's an area that we're particularly interested in building capacity in over the next few years. We just began a small project that we're supporting our outpatient mental health and addiction services team, who received a philanthropic gift from the Hoveda Foundation to bring our Peer Bridgers program into the psychiatric emergency services, into the PES. So this is, again, kind of a first of its kind of actually utilizing peers in crisis emergency response for us at Harborview, starting to think about how do you integrate peers. There's such a core, the use of peer support specialists and people with lived experience are a core component of how locally and at the federal level, people are thinking about the redesign of crisis services, and that in a mobile crisis response, it would include a mental health clinician and a peer support specialist. It's some of the crisis receiving centers and crisis stabilization units that people are talking about, that it would be staffed with mental health professionals and peer support specialists. So really starting to kind of unpack that a little bit and understand what are the roles of peers in emergency and crisis response services, what kinds of infrastructure and training and supports are they going to need to be successful in those environments. And so this gives us an opportunity to do that. By the funding is allowing outpatient services to hire 2 peer bridgers to work in psychiatric emergency services over the course of 2 years. And then we have been working with folks internally to design an evaluation, and we'll collect some data to evaluate that program. So this is some examples of what we want to do and how we're doing it, and what that pillar is designed to do. So just wanted to spend a few minutes talking about what's next for the BHI. I know this has been a lot of information. We're doing a lot of different things. Hope it gives you a little bit of a flavor of who we are, how we work, and how we might be of help or a good partner in some of the things that you guys are doing to advance behavioral health. We do have a few areas that we are particularly focused on and interested in advancing in the next couple of years. One is the crisis response, as we're in it already, and we want to continue that space to develop both innovations in crisis response at Harborview, and then thinking about also in this moment of big system change around the statewide crisis response, how can we help and support that effort? So I talked about our thinking about and design work for crisis stabilization services. We also know that there is going to be significant need for workforce to work specifically in these different areas of crisis, from the call centers to the mobile crisis teams to these crisis stabilization units. And so thinking about what are the optimal skills and competencies of that workforce, what kind of training are they going to need? I mentioned the particular role of peer support specialists in crisis response and how can we best support that. So that's something that we'll be focused on. The BHI also will be doing some work under the umbrella of the CRIS work that I mentioned earlier, coming out of House Bill 1134 from this session, to do a kind of a current state assessment of training requirements across the various positions and licensures, what and how many of the future workforce are going to need to be trained, to include not just the behavioral health workforce, but first responders as well. Just kind of set the stage for a statewide training plan that the Healthcare Authority will be working on. And then I mentioned our desire to increase our capacity in the work that we're doing in our research and evaluation. And I think that any large-scale system change will require evaluation and really close looks at impacts of those changes, good, bad, and all around. And so we want to be able to help support the state in looking at the impacts and the outcomes of the redesign efforts that they're doing. We also want to continue to improve access and standard. Oops, flip back, Melody, I was not quite done. Improve access and standards in substance use treatment. Melody and her team are doing some really interesting work around a provider assessment tool to help support the SUD providers in particular in what kinds of infrastructure and what do they need to effectively implement evidence-based and best practice approaches in treatment. It's been a struggle for those providers that tend to be smaller and under-resourced significantly to figure that out. And then we're also looking to develop some programs to reduce length of stay and facilitate community placement. One of the things that we're really interested in, what does the support mean in supportive housing? So really, how do you help individuals with mental illness and substance use get and maintain housing and bring care to them? And what are the models of care that look like bringing healthcare to people where they are, both health and mental health? How do we leverage some of the initiatives that are in place or coming to the state around support for social determinants of health, like the 1115 waiver or the Apple Health and Home legislation that was passed a couple years ago. And then we did also recently submit a grant to the Substance Abuse Mental Health Services Administration to train low-income housing staff in mental health awareness and de-escalation. We know that it has been a struggle. Many of the low-income housing staff are not trained. They're not mental health professionals. They're not trained in mental health, and yet they are housing a large number of individuals who are struggling with mental illness and substance use. And so helping them be able to provide support and on campus. Next slide, and where this is the last one. So we're about to wrap up to take questions. And then I think just in our workforce development and training, we will continue to build off of the incredible work that's already happening and all the projects that Melody mentioned, and then some. So we hope to be able to continue to expand and enhance the behavioral health apprenticeship program, bringing on both more employers and more apprenticeships, apprentices themselves into the field and into the work, and working with others around UW, around now that we're sort of creating this new kind of workforce, these enhanced positions or non-licensed position, some guidelines around how to optimize their use, how to integrate them into treatment teams and what that looks like. We'll obviously continue our telebehavioral health series as well, and then continue to find ways to advance equity and social justice within the behavioral health system. So with that, I'm going to stop. I know that was a lot of information, but I do hope that it gave you a lot of flavor about who we are and what we're doing. And I think we'll, Joe, turn back to you or open up for questions.
Thank you, Susan and Melody. Information on what you've accomplished, your future directions, areas you want to develop, and a lot of time for discussion and questions. So very interesting. I'm glad we have this time. I think I would like to encourage any participants to write in with questions, comments, and we can discuss them. I'll start with one question that came in. Melody, I believe while you were presenting, Susan, you may have spoken to this sufficiently, but Melody, there may be other points about training that covers education on providing care for diverse communities. Is that part of the training? Are there aspects of the training that you'd want to comment on?
Well, I think that would be our effort around that has to do with our race equity and social justice work. And Susan mentioned the most recent call to action series, which was the BIPOC convening, or I mean the convening for mental health and behavioral health for folks in our Black community. And it's an ongoing effort that I'm sure as our training offerings evolve, we could be touching on additional things in that area. Susan, do you have anything to add?
Yeah, I mean, I think that's right. It's something that I think there's a huge need for. We would love to see more of that happening. I'm working right now with Sarah and her team at CoLab, who has a project that they're being funded for culturally responsive care in the children and youth world, and trying to think about what that looks like. How do you train to it? So we'd love to do more work in that space. We think it's a really important body of work, and there's a huge need for it. We know, and we hear that all the time from our communities of color that are telling us, we need to think about care through that lens.
Susan, it's interesting you mentioned CoLab again. That happens to be the Grand Rounds presentation on Friday, June 2nd.
Oh,
so I encourage,
that's awesome.
I encourage people to come back Friday, June 2nd. Anyway, we'll move on with questions here. I was wondering, I encourage other participants to write in with questions and comments, but I will pose a question where one point towards the end that caught my attention was on research and program evaluation. This is an area you want to move. And you meant, I think the slide, and you mentioned recovery and quality of life. Are those specific outcomes that you're interested in research, or is it within those domains? Or could you comment on that?
Yeah, I mean, I think, what I would say to that is, of course, at the end of the day, that's what we're looking to help people achieve, right? Recovery and quality of life. And that is the ultimate outcome. But I wouldn't say our research interests are limited to that. I mean, we're very interested in research that is studying new and innovative advancements in treatment, and everything from clinical trials to programs and evaluating them to see their effectiveness. One of the ways that we tend to operate is getting input, like community input and about what's important to them and what outcomes look like. And so I think any research that we do, we would want to be really participatory research in that sense of looking at that. But we're really open to ideas and thoughts, especially that span kind of the categories from crisis response, particularly crisis response, substance use disorder, issues of equity, and outcomes related to some of our BIPOC communities as well.
Thank you for that response. I don't see other questions that have come in, so I guess I'll ask another question related to this. So I've learned today that it's not, I guess in my mind, I thought Behavioral Health Institute was a location in addition to the work that's being done, but it's people working in many places. We were talking a little bit about this ahead of time. And does one sort of apply to work with BHI? Is one contacted by BHI staff? How do collaborations begin? How have you seen that go?
Yeah, that's a great question. Thank you for asking that. And really it could be an either or. So we welcome people reaching out to us that have similar interests or are working in this space, and we have this quite a bit with folks in the UW system where we have conversations and be like, wow, where are there opportunities? And that's why I really wanted to encourage this group to think about, like, where might there be intersections with the work that you're doing? But we also reach out to people, like we may get a contract to do something, and we aren't the subject matter experts, or we don't have that subject matter expertise. And so we will look to find folks within the UW system. That's where we start. And hopefully, usually we can find it there. If we didn't, we'd probably have to go out of the system. But we also reach out to folks and say, hey, we've got this exciting opportunity or this project that we're working on. Would you be willing and interested in being a partner? And we've done that. And I think you've seen that. Melody certainly talked about a couple of times when we've done that with ADAI and Mandy and others to pull them in because they really are the subject matter experts. So it can happen both ways. And I'm glad you brought up the building thing, because a lot of people, so I should have said that to this, that should be my opening line, that the BHI is not a building. I think it got sort of wrapped up in some of the master campus planning work that's going on over at Harborview and the bond, but we are really a center and a set of programs and a think tank for innovation in the behavioral health space. And someday we might have more new space and a building, but that's not who we are.
I want to just check. Thank you, Melody. You added in your email address for contact. I don't see another question. I'll ask. I mean, there's workforce training, workforce development, which clearly you have many roles in. What about local trainees in psychology, psychiatry, social work within UW? Are there relationships there? Is that part of a focus of projects or BHI?
Yeah, so our focus has really tended to be outwardly focused on kind of both the current workforce, so people that are working in community behavioral health who may not have access for lots of different reasons to training, and also the entry level non-degreed workforce that's happening through our apprenticeship program. And I say that that's been our focus because there are others within the UW system that are very focused on sort of the varying degrees through different departments, whether it be a bachelor's degree, master's degree, all the way up through the School of Medicine. you know, being one of the largest psychiatry residency training programs. So we do work very closely with, you know, folks that are doing that sort of more college level degree programming. Our focus tends to hopefully complement that. We're very interested, as Melody was talking about building pathways. Like, it's one of the reasons why they spent so much time on the apprenticeship program, making sure that the training that they were getting could transfer if somebody wanted to go into a college pathway and further their degree, that they could get credit for the work that they're doing. Melody, is there anything else that you would add to that?
Yeah, just to highlight what you said about that we're interested in leveraging partnerships but not doing things that we already have great efforts happening around. But the collaboration with Department of Psychiatry, like Anna Ratzliff and the AIMS Center and ADAI and Dr. Sarah Walker CoLab, those are looking at how our workforce efforts, both from a workforce production angle and a workforce training and development angle, how those bodies of work can intersect with the further degree pathways is of great interest to us.
The one other thing I will say, though, is that people that are rotating through Harborview clinically for practicums and things like that could potentially get exposed to and, you know, become part of some of the clinical innovations that we are doing at Harborview, if the timing was right and all of that, right? That they're going to get access to or maybe observe or be trained in some of those practices at some point.
That's good to know. There's often trainees with an interest in quality improvement, process changes. I mean, these are people with high clinical demands and often are very aware of processes, and so on individual patient levels, and so there's often
Yeah, and the same could be true. Again, we haven't fully developed our research and evaluation arm yet, but I could see that also being a place where, you know, there might be opportunities actually for capstone projects, these like, you know, or just general research interest that students might have.
A couple of questions came in. I'll go back. One is maybe this is more organizational clarification about BHI within UW. I mean, you mentioned it's part of Harborview, report to the CEO, part of yeah, maybe I'm not going to say it. Yeah, I will say it incorrectly. Susan, would you say the truth there? How is it organized? It's not part of the department. It's part of something. You know, just say the organization again. I think for clarification.
So, our organizational structure. So I am at Harborview. I report directly to the CEO of Harborview. And the institute itself is governed by leadership across Harborview, UW, and UW Medicine. So hopefully that helps.
Thank you. Thank you.
We don't sit, I will, maybe a clarifying point. We don't sit in the Department of Psychiatry and Behavioral Sciences, for example. We're not a center of the department or any department for that matter. We really are housed in Harborview and part of Harborview, but we have that linkage. And, you know, some might say in an organizational world, the dotted line matrix to, you know, the department to Jürgen, you know, who's on our steering committee, and kind of that connection link to UW in general.
Susan, is that unique in Harborview, or are there other examples?
I think we are the only one of our kind, as far as I can tell. I think most of the other centers that exist at Harborview are actually Department of Psychiatry and Behavioral Health faculty centers. Like, I'm not a faculty at the department, in the Department of Psychiatry and Behavioral Sciences. This is kind of completely sits outside of that. The other centers are all, I think, embedded within the department in a different way than we are. So if there is, I'd like to know, but I'm not aware of any other center that's situated like us. It's been kind of a challenge and an opportunity. It's part of what the evolution of the entity has been to kind of try to figure that out. And what does that mean? Because we do kind of look and operate a little bit different than some of the other centers.
Thank you. And I'd like to encourage any last questions to come in. We have a minute or two. There is one more question that came in, I believe, as a follow-up. about the social justice work, about individuals being compensated for participation, for being on committees. Is there, this in research, there's incentives, how does that work in your case?
Yeah, so it is definitely our value to compensate people for their expertise that they're bringing if they're not being compensated by being there as part of their job. So we are able to do that in different avenues of the work that we are doing for the BHI. The CRIS committee that this has been a big issue with the crisis response redesign, which is actually, state authority, and we've been an advocate and working with the state to get all of the individuals who are on the committee and on the subcommittees that are not getting paid for their job, and particularly individuals that are low income or with lived experience, reimbursed for a stipend for their participation. So it is definitely a value of the BHI, and we do everything that we can to ensure that that happens.
Well, I think I'm checking the chat too. I don't see other questions that have come in. We may just wrap up a minute or so early. But I do want to thank you both. Thank you, Susan. Thank you, Melody. I appreciate your efforts on a joint presentation, alternating who's presenting topics, giving us really a range of what's occurred over the last 5 years, next steps. I appreciate this a lot. Thank you for presenting today.
Thank you so much for having us. Yeah, and anybody who's interested, please don't hesitate to reach out to Melody or I.
All right. Very good. Well, we'll end Grand Rounds there for today, and take care.
Take care.
Thank you.